Good morning, ladies and gentlemen. I am Dr. Clarence. This talk is pre-recorded, but I hope to log in during the Q&A. If not, we can also discuss over the email or the WhatsApp. This topic is a very common condition, medical management of BPH, benign prostatic hyperplasia. So what is this organ, the prostate? The prostate is a very important organ. To me, it's a sexual organ. It's responsible for production of semen and, of course, associated with ejaculation and erection. Of course, nearby, we also have the bladder, we have the urethra, we have the sphincter, we have the lower ureter, and, of course, we have the kidneys. So all these can produce urinary symptoms. But today, the focus is on the prostate gland. In particular, is on BPH. BPH is benign prostatic hyperplasia. It is enlargement of the prostate caused by overgrowth of prostatic tissue. It is a histological diagnosis. So if you look at the anatomy of the prostate, if the prostate gland enlarges, it seems intuitive that it will cause obstruction, but it may not be so. In fact, if the prostate gland enlargement is in the periphery, it will not cause obstruction. So it doesn't mean that an enlarged prostate will always give rise to symptoms. There are many other factors which give rise to urinary symptoms, especially the bladder, the sphincter, and even factors from outside the pelvis. So what's the new things that I'm going to cover today? So the first thing is that, although we use the word BPH, nowadays, most of the urological texts will refer to it as male LUTs, lower urinary tract symptoms. But of course, 2/3 of the male LUTs are actually due to the prostate. And we also do not put in a histological diagnosis. We put in BPEO, which is benign prostatic enlargement obstruction, or BPO, if the prostate is not so enlarged, we call it benign prostatic obstruction. And then I'll talk about the medications for the prostate. There are two classes of medications and the specific types. And I'll talk about the cost economics, and also I show some cases and my preferred choices as usual. Now, what are the medications for the prostate and the bladder together? When do we start, or when we don't have to start? What are the specific medications? What is the efficacy, the side effects, the dosage, and then how long does we have to put on the medications? Do we take it forever? Okay, so now the next slide is on the epidemiology. So as you can see from this graph, it increases with increasing age in all the countries. I'm 65, so there's a more than 65% chance that I have prostate enlargement, BPH. So if you look at your demography of your practice, you'll find that many of your patients indeed have BPH. But what about clinical presentation? This is a study done by the Malaysian Morbidity Survey, and they find that average of 16% of men have clinical male LUTs. So what are the symptoms of male LUTs? The first symptom, the commonest symptom, is nocturia. And by nocturia, we say passing urine once a night, from the time you sleep and from the time you wake up. And whereas polyuria refers to production of more than 1/3 of the urine volume. Okay? But then a woman also have nocturia, but they have no prostate. So be very clear in your mind that it may not always be the prostate. So let's talk about nocturia in a bit more detail. In one of the landmark publications by Dr. Tay Kwan Chow in the Malaysian Medical Journal in 2011, they looked at a study done during the Prostate Awareness Week in Hospital Kuala Lumpur, and they find that 56% of patients coming for so-called prostate concerns have nocturia, and another 50% has frequency, and equally big group have got a sense of incomplete voiding. What about in Asia? We did a survey in Asia, including Malaysia, and we find that, again, nocturia stands out as the most significant symptom when patients go and see a doctor for so-called prostate concerns. Well, what is also interesting from this survey is that 78% of patients in Malaysia and Asia actually depend on medications if they require treatment. And a good percentage of them, 14%, 13%, actually did not take any medication. And only a minority, about 8 and 9% of them, actually went on to surgery. So this is the spectrum of the condition called BPH, which can be generally managed in the community. What about other factors? Other factors are the bladder. The bladder may be overactive, may be underactive, may be dyssynergic. You may have bladder cancer, you may have a urethral problem, you may have a stone, especially lower ureter, you may have problems from your cervix, from the rectum, and of course, don't forget the kidneys, which produce the urine. And all these are controlled by the nervous system, in the spinal cord, in the pelvis, in the brain, and of course, we have to consider the endocrine system as well, the antidiuretic hormone. So when we're taking a history, how do we quantify the symptoms? There's the thing called the IPSS patient questionnaire. International prostate symptom consists of 7 symptoms, 7 symptoms, and you can quantify it according to how severe is the symptoms. But what is the most important question, which is not on the list? That is the quality of life score. Many patients in Asia and in Malaysia, they can have a lot of symptoms, but they say it doesn't affect me. My flow is slow. It has been slow for years. I'm quite happy, just that I drive my car slowly. So the quality of life is an important question as well when you assess these patients. What is the symptom that bothers them the most? And you go for that treatment. So if the patient said, my flow is okay, it's slow, it doesn't matter, but my problem is frequency urgency. Then you have to address to treat the frequency urgency. Next, we go to the clinical evaluation. You have to examine the patient. Some of these elderly patients, especially if they're diabetic, they've got severe fibrosis. So that may require some surgical treatment. And if you are the only patient, only doctor managing the patient, you have to do a rectal examination. Look for nodules, hard prostate, lax anal tone, constipation, sometimes even a growth in the rectum. So that is important. And a urinalysis. If the patient has got blood, you may think of tumor, you may think of stones. If the patient has got nitrates or leukocytes, you may think of infection. So these are the basic investigations you have to do for the patient. And in my routine practice, all the patients will of course have the vital signs taken as well as the random blood sugar, because diabetes is so common, hypertension is so common in Malaysia. So that is my basic clinical evaluation before I give them medical therapy. What about investigations? Patients love to have some kind of scan. And I think for most doctors, the ultrasound is an extension of your clinical evaluation. Look for hydronephrosis and look for stones. So this requires surgical therapy. When you scan the bladder, you look for the bladder volume, look for the bladder wall thickness, and sometimes if we can see an intraprostatic protrusion, or what they call the median lobe, that puts them on a higher risk of bladder outlet obstruction. In fact, Professor Katie Fu in Singapore GH said that more than 80% of them will have a bladder outlet obstruction. And in another study which is published said that if you have a significant intraprostatic protrusion of more than 10 millimeter, there's a 50% chance that you will eventually have urinary retention. So ultrasound, I think, is easily available, and most clinicians, whether you're a family physician or emergency practice, you will have an ultrasound and it gives you a lot of information. What about specialized investigation? To me personally, it's extremely important to do a uroflowmetry. Of course, you don't go to the toilet and look at the person passing urine, that will be abnormal. So usually we ask them to do a uroflowmetry in a special device in the toilet. Now, I'll tell you an example of 2 recent cases that I saw. One is an engineer, and his concern, the patient's concern, is that he has got the raised PSA. The doctor who examined him did an ultrasound, did the rectal examination, said his prostate is enlarged. So he said, you've got enlarged prostate, I give you medication for enlarged prostate. But that is actually not treating the underlying problem, which is the patient's concern whether he got a prostate cancer. So I have another patient also similar like that. They have a high PSA, they are concerned about cancer, they have a family history of breast cancer, prostate cancer. So it's a different thing. So you very make sure that when you treat the patient, there are 3 conditions in the prostate: cancer, BPH, and infection. So now I elaborate a little bit on my pet topic of uroflow. So if you look at this, this is a meter that we place in the toilet. The patient passes urine to the toilet, and the normal flow is 15 mils per second with a bell-shaped curve. So if any other curve is abnormal, it may mean that the patient has got a urethral stricture. If it's a flat curve, if it is an intermittent flow, it may mean that the patient has got some kind of obstruction due to the prostate or due to dyssynergia, or sometimes they may have a stone in the bladder. So the uroflow is very non-invasive. I encourage that all urologists should try to use the uroflowmetry before they start a patient on long-term therapy, and especially if they are going for operative therapy. Of course, if the patient is retention, is a different matter. The next thing we talk about medications. So the patient has an enlarged prostate. So the patient wants a medication to shrink the prostate gland. You go and see the doctor. If the doctor gives you a medication to shrink the prostate gland, it will take months. So the doctor will usually not give you a medicine to shrink the prostate. He'll give you a medicine to relax the prostate, to relax the smooth muscle, so that it can pass urine better. So these are the 2 types of medications which you can use. Of course, if you give them a medication to shrink the prostate, it can last longer. But it takes a long time for it to work. And there are 2 types of them. Up to now, there are only 2 types of medication: finasteride, which is available in a generic form, and dutasteride, which is supposed to be a dual inhibitor of the 5-alpha reductase in the prostate gland. It reduces the intraprostatic dihydrotestosterone. Now, how do we compare these two? If you give them an alpha blocker, it will work almost immediately, within hours. But if you stop the medication, the symptoms will come back. After 2 or 3 days, it will come back. And it doesn't affect the natural history of the condition. In other words, the patient will still have retention. Later on, if you stop the medication, the prostate will continue to grow. But if you give them an alpha blocker, it will shrink the prostate gland, and therefore, hopefully, in the long term, they have a less need for surgery. Now, these are the pros and cons. Now, what about the cons? What are the problems with taking the medication? Now, tamsulosin is actually alpha blocker. And only the first alpha blocker is prazosin, which is used for hypertension. So they have problems with hypotension, postural hypotension, dizziness. Sometimes they call nasal stuffiness. The dutasteride works on the testosterone pathway. So they have problems with decrease in seminal volume. Some of them have decrease in the libido, and sometimes they have gynecomastia. So these are the symptoms. Of course, if you take both the medication, I suppose the side effects will be more. Now, if you look at the drug insert for dutasteride or finasteride, you will see the report that patients who take dutasteride and finasteride have a higher incidence of high-grade cancer of the prostate. And not only that, they may have irreversible erectile dysfunction. So quite a few of my patients, they get access to this drug insert or they go to the internet and they're very concerned. Personally, I don't think this is important. The high-grade prostate cancer is probably because the prostate becomes smaller and therefore they diagnose more prostate cancer. But nevertheless, the patients will ask you these questions. So you have to be able to discuss with the patient regarding the side effects. And of course, the pros and cons are pros and cons. If they have got a lot of dizziness after taking the medication, maybe they take the medication at night. So these are all the medications that is available in the private sector, in the government sector. Different kinds of alpha blockers, prazosin, tirazosin, doxazosin, and there's also a combination of dutasteride plus tamsulosin, which is called duodat. Okay, so if you take monotherapy or dual therapy, is there any difference? Of course, if you take dual therapy, then the dutasteride component will shrink the prostate, and in the long run, they will have less risk of surgical intervention, less risk of surgery. Now, what about some patient demographic and personal experience? Before I came over to record this, I asked my pharmacist in this hospital and said, how is my usage like? And in fact, I have quite a big usage of patients on this dual medication. In fact, 56 of the patients. And they are generally speaking in the older age group. The mean age is 70, although the range is 48 to 95. So if a patient who is under 50 years old, he's probably having his symptoms not from a prostate enlargement. Now, as a general doctor, as a general practitioner or medical officer, when do you refer the patient? Must you refer every patient? Must every patient go on medication? The answer is no. In fact, only 16% of patients will deteriorate in their natural history. Some of them will actually improve because there are many other factors to urinary symptoms like exercise, your dieting, the metabolic syndrome, and only 1% of them will actually get obstructive uropathy. And these patients, you can pick them up because when you do ultrasound, they have hydronephrosis. But if the patient has got recurrent UTI from the chronic retention, have stones, have symptoms which bother their quality of life, then maybe these are the patients that you can refer to a urology clinic electively for urological assessment before you put them on long-term medication. The important thing is to pick up the group of patients who will deteriorate. In other words, they may require early treatment or they require surgery eventually. So these are the 6 so-called risk factors for clinical progression of BPH. Advancing age, although it's 62, I don't consider 62 as advancing age, but this is what is in the studies. A high prostatic volume, high PVR, a post-point residue of 39. To me, that actually is very low. Increased prostate volume of 40 mils. So if the patient has a prostate of less than 40 mils, then you should not give the patient drug to shrink the prostate gland. So I see a lot of patients who are just giving dual therapy just because they have urinary symptoms. And of course, if the urine flow is low, less than 10.6, they have a higher chance of going to retention and surgery. And if they've got moderate symptoms instead of mild symptoms, and of course, if the PSA is high, PSA ranging from 1.4 to 1.6, this indicates the prostate is enlarged, they probably do better on dual therapy. So in conclusion, which are the drugs we use for patients with male LUTs due to BPH? First, most people will give them an alpha blocker for a couple of weeks. And if the prostate is enlarged, then you can add on a 5-alpha reductase inhibitor like finasteride. But if the patient said, money not concerned to me, and he understands that, you know, the expensive component actually is the finasteride, you can give them a dual therapy straight away. So many of our patients say, okay, we start on an alpha blocker, and we give them a good alpha blocker, uroselective alpha blocker, and if it works, then we can titrate backwards. We can de-escalate the medication to something which is more affordable to the patient. Patients who have got a lot of side effects from alpha blocker, or patients who are already hypertensive, many of the elderly people have got cardiac concerns, the blood pressure is already 95 or 60, then these patients should not be taking an alpha blocker. They can just go on 5-alpha reductase inhibitor, but it takes time for the medication to work. Yesterday I had a patient, he's taking dual therapy. And he said, oh doctor, you know, this is quite expensive, you know, and I read in the drug insert, I can get permanent erectile dysfunction, I can get cancer prostate. Can I reduce my medication? And of course, there are studies to show that if you're taking the dual therapy after 6 months, many of them, up to 77% of them, you can take off the 5-alpha reductase, take off the alpha blocker. Okay, so you can de-escalate the medication. Usually, to me, I don't start them a treatment for the urinary frequency unless they have bothersome symptoms after a period of treatment for the BPH. So it's up to you to discuss with the patient in terms of the side effects, in terms of the cost economics, which medication to use. Now, finally, in fact, there's so much publication. We have got the consensus from Malaysia, we've got the European guidelines, we have so many studies. So again, you can refer to these studies when you need to have more information on this topic. So this is my last slide. So thank you very much for your attention, and I hope to be able to have some discussion with you either in live or through WhatsApp or through the chat box. Thank you so much.